control over that arm or active movement. And then the arm can be positioned such. However, in many stroke patients, they run the potential of having a lot of swelling in their arm, and to have it in this flat manner may help their trunk control, will be a good position for their arm, but it does not help with swelling. So very frequently we add a foam rubber wedge. The flat, the back part of the wedge, goes against the back part of the trough. We'll demonstrate that. It just easily fits down, pushes into the trough rather snugly, and also gives some extra elbow cushioning that the towel does not always afford. And it keeps the patient's hand in a functional position that's perfect for the swelling to decrease and go back up into the body. Okay, we can remove this piece, and we're going to next be looking at a commonly used, although very complicated, sling. First, we should say a few things about slings generally, and that's that a sling is used to support a patient's upper extremity or arm. It's used with a variety of diagnoses, included, again, a patient that's had a stroke that has no functional use of their arm. In that case, it would help support their shoulder in the socket, give support to their wrist that generally is in this type of flaccid, we call it, position. There is no control. It's used for patients with dislocated shoulders or rotator cuff tears, or even patients with mild fractures. I brought this sling today because it's probably the most complicated of all the slings that you will see. I'll show you how that goes on. First of all, there's a cuff area. It has a back strap, and that should be your sign that this, you know, is for the elbow. You can go around the back of the patient, one strap in front and one strap in back, and again to the front, one strap in front, one strap in back. The hand is put through, and the wrist and hand are supported, and then a Velcro strap across the two holds it in place. You should always check the back to make sure the straps are positioned appropriately. And now we're going to have our helper stand up and turn around slowly to show you the circle ring position and this proper strap formation for a sling. There's a few general things I'd like to mention regarding slings before we go any further, and that has to do with sling wearing schedules, which can vary. Sometimes the doctor's order will say on when up. That means that when the patient is out of bed, the sling should be on. And the arm is generally positioned on a pillow, and your therapist will tell you how that should be at night when they're in bed. Or the order could read on for ambulation and transfers, which means that's the only time that the patient would require a sling. And very frequently a patient is, when sitting in the wheelchair, will use the trough or the tray when in the chair, and for transfers and ambulation will require a sling. In other events, an order may read that the sling should be on at all times, and that means in bed, in the wheelchair, or when transferring and ambulating. I'd now like to give you a few common tips to remember that are very helpful with all slings. Number one, read the manufacturer's instructions for application. In-servicing and printed materials will be supplied by the occupational or physical therapist. Number two, support the hand and fingers within the sling. Number three, when the sling is properly applied, it should support the elbow and shoulder in good alignment. Number four, straighten clothing inside the sling to prevent pressure areas from sleeves bunching. And number five, check that the sling is positioned properly and does not pull on the patient's neck. Most frequently, directions and illustrations will be posted in a patient's room or in the care plan. We're now going to turn our attention to splints. Splints can be either fabricated from rigid or soft materials. They can be prefabricated from a splint manufacturing company, or fabricated, that means made, molded by one of the therapists, an occupational or physical therapist. Splints also generally have different wearing schedules. Sometimes they'll say on AM, off PM, check 1 or 2 times daily for hygiene to the splint to be removed and the hand washed. Today we're going to start with looking at a functional hand splint. This is called a stockinette. It's the first piece of equipment that goes on the patient's arm. It acts as a little bit more of a cushioning element and helps decrease skin breakdown. We're going to be applying the functional hand splint, which is a rigid splint. And today I have used a prefabricated splint made by a company, but again, these can be fabricated by therapists. It supports the thumb in all of the digits and the wrist in alignment. It's used on patients that have wrist drop, and I'll show you what wrist drop looks like in a minute. A patient that's had a stroke often prevents with no active movement at all of specifically their entire arm, but this is to address the areas of the wrist and fingers and to keep it in alignment. It can also be used on a patient that has tone. That means the hand is starting to get tight. It's difficult for a caregiver to passively open the hand, and this helps to create and maintain that spacing so that the fingers again will become more flexible and the patient will not develop a potential for contractures. So that's our functional hand splint. I'm going to remove the Velcro, and I used a variety of Velcro widths here to show you that you will see a variety out there. There is no precise one or two. There's many. And I'm going to remove the stockinette because next we're going to look at a soft splint. This is called a wrist cock-up splint. I'm going to turn it slowly so you can see that there's a series of D-rings, metal D-rings on this type. And as I turn, there's an accordion-like type of fabric material. I'll get my hand out of there and then put it back in so you can see that it expands and contracts. So this will be able to be fit on virtually any patient's hand, but these do run small, medium, and large too, and that's a help. On the back also, which you cannot see, but you can kind of see the coloration is different, is a hard, rigid bar. Once in a while, that bar will slip right through here at where my finger is, and it should be pushed up back in there and anchored. I've seen more than one patient come to therapy with the bar sticking partially out. It's adhered to the arm with a series of Velcro closures, so we're going to show that.